Okay, hey guys. Just trying to make some final. There we go. Okay, so we're going to do chapter 21, allergy and anaphylactic. Shouldn't be too difficult. We'll move through this one pretty quick, I hope. So our introduction, getting into it here. EMTs are often called involving allergic reactions. Allergy-related emergencies may involve acute airway obstruction or cardiovascular collapse. You may be able to treat these life-threatening complications, distinguish between the body's usual response to an allergen and the allergic reaction. Uh, Immunology is the study of the body's immune system, five categories of stimuli that may provoke an allergic reaction. So just jumping into the anatomy and physiology here. The immune system protects the body from foreign substances and organisms. When a foreign substance invades the body initiates a series of responses to inactivate the invader. An allergic reaction is uh, it's, it's an immune response to any substance, um, not caused directly by an outside stimulus, caused by the body's immune system, releases chemicals to combat the stimulus, includes histamines and leukotrienes. Some patients may not know what's causing the reaction, so you must recognize the signs and symptoms, maintain that high index of suspicion. An allergic reaction may be mild and local or severe and systematic. So, before we get too far into this, an allergic reaction is going to affect one body system. As soon as we have two things take place, it's actually considered anaphylactic. So I'm sneezing, it can be my allergies. I'm sneezing and I'm starting to get hives. Now I'm got mild anaphylactic. Just keep that in mind. One body system, it's just an allergy attack. Two different body systems at the same time, anaphylactic. Anaphylactic is an extreme life-threatening allergic reaction, involves multiple organ systems, can rapidly result in shock and death. I guess I should probably just look ahead instead of talking. Um, the sequence of events in anaphylaxis, the antigen is introduced into the body. The antigen antibody reaction at the surface of the mast cell, the release of mast cell chemical, uh, cell antibodies react with the corresponding antigens, and chemical mediators exert their efforts on end organs. Pretty much what all that rambling is. Allergen goes in or antigen. It's not supposed to be there. Our body sends out those histamines or whatever, and there's this little battle that takes place inside our body. It's an allergic reaction. It's anaphylactic reaction. It's this internal battle between something that's not supposed to be there and our body fighting it. Now, what all it affects kind of gets a little bit deeper. Three common signs of anaphylaxis is hives, a small area of generalized itching or burning that appears as multiple small raised areas on the skin. Most of us have seen hives. Uh, Angioedema, areas of localized swelling. And then wheezing is that high-pitched whistle, breath on expiration. Boy, that woman just looks miserable, doesn't she? You may also note stridor on inspiration due to upper airway narrowing, um, hypotension due to vasodilation and increased capillary permeability, nausea, vomiting, and abdominal cramps. These are all things that might come with it. The biggest thing with anaphylactic shock or anaphylactic reaction is protecting that airway. Our airways will begin to swell shut. Like it says here, we got vasodilation, so everything's opening up, and we got permeability, so we're actually losing fluid out of where it should be. Um, so everything just goes wonky all at once. We can't breathe, our airways closing. Um, so we need to pay very close attention to airway and blood pressure. Common allergens, foods. May take more than 30 minutes to appear. Shellfish, nuts, peanut butter. There's all kinds of stuff out there. People are allergic to eggs. Um, Medications. So antibiotics. Example is penicillin. Non-steroidal anti-inflammatory drugs. And as we go through this book and you guys learn your assessments more and more and more, it will make more sense why we ask those questions when we do our OPQRST and our sample, and we get this information. Um, it kind of just all falls together as we move forward with this. Medications, if medication is injected, the reaction may be immediate and severe. Reactions to oral medications may take more than 30 minutes to appear, but can also be very severe. Um, Plants, so dust, pollens, and other plant materials, ragweed, ryegrass, maple, and oak. Most people just call this seasonal allergies. Chemicals, so makeup, soaps, hair dyes, latex is a particular concern to healthcare providers. Um, we really don't use latex gloves anymore. We use those nitrile or whatever they're called gloves, um, because we don't have to worry about latex allergies that way. Insect bites and stings, envenomation, the process of an insect injecting its venom. Reaction can be localized or may be severe and systematic. So insect stings. I promise I'm not stroking out. Approximately 2 million Americans are allergic to the venom of bees, wasps, and hornets. Allergic reactions to insect stings cause at least 62 deaths a year in the United States alone. In about half of these deaths, the victim had never experienced a reaction prior to a sting. The stinging organ of most insects is a small hollow spine projecting from the abdomen. Sorry, I am scanning my book really fast. Okay. Um, Honeybees cannot withdraw their stingers. Wasp and hornets can sting multiple times. Most of us have learned this the hard way. Some ants, especially the fire ant, strike repeatedly. Signs and symptoms is sudden pain, swelling, localized heat, uh, those hives, redness in light-skinned individuals, itching, and I think that's supposed to be a welt. Um, in severe anaphylactic cases, patient may experience stridor, bronchospasms and wheezing, chest tightness and coughing, dyspnea, anxiety, gastrointestinal complaints, hypertension. Once again, I'm going to back up. ABCs. We all know what those are by now. We've got to protect that airway, monitor that breathing, and pay attention to especially blood pressure, which is circulation, um, because it can rapidly, and when I say rapidly, I mean within 3 to 10 seconds, someone can close up. So really watch these people. Uh, Patient may occasionally experience respiratory failure. If untreated, anaphylactic reaction can proceed rapidly to death. More than two-thirds of patients who die from anaphylaxis do so within the first 30 minutes. I don't know if it's said or not, or if I've already said it. If we can find out what caused the reaction, let's go ahead and do that. Don't be out there trying to take a bee with you or, find the wasp that stung someone. But if we have an idea when we arrive on scene and we notice one, ABCs always, um, make sure it's safe for you to run in there. Don't run in there if there's 500 wasps flying around. But we need to get that person away from whatever's causing the reaction. So if it's plants or if it's pollen, or we just need to get them away from what's causing the reaction so we can start treating without it becoming worse. So you're seeing size up, seeing safety. The patient's environment and recent activity may indicate the source of reaction. Stings or bites, food allergies, new medications, medication regimen. Be mindful of other potential causes of respiratory distress. Traumatic injury may also be present. Follow standard precautions with a minimum of gloves and eye protection. Consider the need for additional resources such as ALS personnel, and mainly because depending on protocol, we can push or we can start fluids, we can push that epi. Um, it all depends on what your protocol is. Um, let's see. They bring up a good point here. Traumatic injuries may also be present. So I'm just going to throw a scenario out. You're up on a ladder repainting your house, and a wasp stings somebody and they fall off the ladder. Well, now we've got anaphylactic because they're, swelling up, but we also got this trauma going on. Um, so just keep in mind when we go on these calls, study your scene. Use that index of suspicion, or my favorite word, common sense. Quickly identify and treat any immediate and potential life threats. Form a general impression. May present as respiratory or cardiovascular distress in the form of shock. Patients often appear very anxious. Call for ALS backup if available. Look for a medical identification tag. Everybody uses their iPhones now or their cell phones. Um, get information that we can, which we'll talk about history here in a minute. Airway and breathing, anaphylactic can cause rapid swelling in the upper airway. You have only a few minutes to assess the airway and provide life-saving measures. Work quickly and determine the severity of the symptoms. What I teach most of my classes is if you go on an anaphylactic, when tones drop and they say allergic reaction or anaphylactic shock, um, I'll have someone drive. I have my partner or me get in the back, and we go ahead and lay out everything we think we might need airway wise. We don't open it, so you're not wasting material, but it's out of the cabinet and it's laid out. So if I need to intubate or I need to drop an airway, within 30 seconds of being on scene, I've got everything ready already. So just keep that in mind. I'm not saying you have to do that. It's just a good practice. Airway and breathing. Quickly assess for the increased work of breathing, use of accessory muscles, the head bobbing, the tripod position, nostrils flaring, abnormal breath sounds. This is everything that we learned back in like chapter 16 with airway emergencies. Assist the patient into high Fowler position to maximize ventilations. Uh, if signs of shock, place that patient in a supine position. Cover them, apply high flow oxygen. Do not hesitate to initiate high flow oxygen. In severe situations, assist using a bag max device attached to oxygen. Circulation. So may present with hypotension. So we've got that low blood pressure. Palpate the presence and quality of the radial pulse. So when we get pulses, we do what? We check the pulse, we check the quality, we check the rate. We're also checking skin at the same time. Assess the rapid pulse rate, cool cyanotic and red moist skin. May indicate hyperperfusion. So if we got shock, that is definitely a life threat, right? Treat for shock. Definitively treat for anaphylactic shock. Uh, is epinephrine. Once again, know your protocols. Know your epinephrine dose. Um, it doesn't hurt to, every once in a while brush up on the anaphylactic shock skill or the epinephrine administration skill. Look it up in your protocols. Have an idea of how to do it because when that time comes and you have seconds to react, I promise you, you're going to wish that you had studied it and you had practiced it. Transport decisions. Always provide prompt transport for any patient who may have an allergic reaction. If the patient does not exhibit severe symptoms, consider continuing to the assessment. Err on the side of emergency transport. You know what? In anaphylactic shock, if there's even the slightest chance that they are going into that shock, we got lights and sirens for a reason. Just be safe about it. History taking. So we do need to investigate that chief complaint, history of present illnesses, identify associated signs and symptoms, um, your respiratory, cardiovascular, skin, and then your other findings. I preach this throughout my entire course. If you follow your skill sheets that we learn, no matter the call, you can work any call. I don't care if it's a wasp sting to a gunshot. If you follow your skill sheets and you learn them, then you will 9 times out of 10 be successful on a call. Sample history, if possible, ask the following questions. Have any interventions already been completed? Has the patient experienced a severe allergic reaction in the past? Do you have an EpiPen? Have you taken Benadryl? Um, did you wash the site? Is the stinger still in there? Or did you scrape it out? Be alert for any statements regarding ingestion of food that caused allergic reactions. Ask about the gastrointestinal complaints like nausea and vomiting. Physical examination, so systematic head to toe or focused assessment. Auscultate for abnormal breath sounds, wheezing, and stridor. Inspect the skin, swelling, rash, and hives. Um, when we do our skills days in class, I'll use the electrical mannequin and we will listen to lung sounds and I'll show you what wheezing sounds like, what stridor sounds like, what crackles are. So we will get to practice listening to these sounds. It's not just reading it in a book. You can also go on YouTube. They have really good lung sounds you can listen to. Assess baseline vitals, pulse and respiratory rate, blood pressure, uh, pupillary response, sorry. Oxygen saturations, skin signs may be unreliable. So I'm preaching to the choir here. Pulse and respiration, rate and quality. Get that in your head now. Monitoring devices. So pulse oximetry can be a useful method to assess the patient's perfusion status. The decision to apply oxygen should be based on the airway patency, work of breathing, and abnormal lung sounds. Repeat the primary assessment, reassess that patient's vital signs, and repeat the focused physical exam. If patient is unstable, reassess every 5. If they're stable, every 15. Watch for signs of shock. As always, when you're done assessing, reassess. You have nothing better to do. Interventions determine the severity of the reaction. Mild reactions require supportive care and monitoring. Anaphylactic requires epinephrine and ventilatory support. Transport to a medical facility. Recheck your interventions. Communication documentation. Documentation should include signs and symptoms, reason why you chose to provide the care you did, and the patient's response to treatment. Let me see where this is going next. Okay, I'm gonna back up a couple slides here. I was gonna throw something in, but I do not remember what it was now. Okay, maybe it'll come to me later. If patient appears to be having a severe allergic or anaphylactic reaction, administer administer BLS, provide prompt transport to the hospital. If you have ALS available, go ahead and get them on the phone. Get them headed your way, meet them part way, whatever you need to do. So if a stinger is present, scrape it off with like a credit card, your bank card, something like that. Don't use tweezers or forceps to try to pull it out. It's not a splinter. Just scrape it off there. Wash the area with soap and antiseptic. Remove any jewelry from the area because of swelling. Position the injected site below the heart. Apply ice or cold packs, not directly on it. Put a rag or a towel or something and then put the ice pack on. Be alert for signs of airway swelling and other signs of anaphylactics. Place the patient in supine position and give oxygen as needed. Monitor the patient's vital signs. So epinephrine mimics the sympathetic fight or flight response, causes blood vessels to constrict, reverses vasodilation and hypotension, increases cardiac contractility, and relieves bronchospasms, rapidly reverses the effect of anaphylaxis. Okay. Epinephrine is prescribed by a physician and comes pre-dosed in an epinephrine injector or EpiPen. Not always. There are services that just have vials that you have to draw up your dose and inject it with a needle and syringe. If a physician has given a patient an EpiPen, you may assist them in using their EpiPen if it's theirs and it's within date. Once again, know your protocols though. Your EMS service may or may not allow you to assist. Okay, we just talked about that. Refer to local protocols. Cool. Uh, all kits should contain a prepared auto-injectable syringe of epinephrine. So your adult epi delivers 0.3 milligrams of epinephrine, where an infant child system delivers 0.15 milligrams. We will practice this in class. I have I have the practice EpiPens that we will practice with. Side effects of epinephrine. Um, you've got high blood pressure, increased pulse rate, anxiety, cardiac arrhythmias. You're going to get pale or paler, dizziness, chest pain, headache, nausea, vomiting. Do not give epinephrine to patients without signs of respiratory compromise or hypotension. Those who do not meet the criteria for a diagnosis of anaphylaxis. That was pretty painless. We kind of went through that quick. The signs and symptoms of an allergic reaction are caused by the release of D. There we go. The negative effect associated with anaphylactic shock are a result of C. You're called to a local basketball park or baseball park, sorry, for a 23-year-old male with difficulty breathing. He states that he ate a package of peanuts approximately 30 minutes ago and denies any allergies or past medical history. Your assessment reveals widespread hives, tachycardia, and a blood pressure of 90 over 60. You can hear him wheezing even without your stethoscope. You should be most suspicious of I'm going to say C. So I'm going to talk about this for a minute. If it was just hives, we would go with D. If it was just a slight wheeze, we could say D. But we've got the blood pressure affected. We've got hives. We've got tachycardia, plus the wheezing. There's more than one body system. It's anaphylactic. Uh, what is a will? So maybe I was wrong earlier when I said wilt. Generalized itching and burning appears in multiple small raised areas. Nope. An area of skin. Oh, maybe it's A. There we go. So I apologize. I was wrong earlier when we did the slide, and I said I think that was wilt. It was will. It's that little white bump that you get whenever you get stung by a wasp. Red around it, but the center of it's white. That's what that is. You're treating a woman who was stung numerous times by hornets. On assessment, you note that some of the stingers are still embedded in her skin. You should check. We don't pull it out, we scrape it. B. A young man is experiencing signs and symptoms of anaphylactic shock after being stung by a scorpion. His level of consciousness is diminished. His breathing is severely labored. You can hear inspiratory stridor, and his face is cyanotic. The patient has a prescribed epinephrine autoinjector. What should you do first? Ooh, that's a tricky one. I'm gonna say A for now. See, I was wrong. Provide ventilatory assistance with bag mask. Okay, that makes sense. So ABCs. Yep, your instructor just failed. Um, we've got to bag him and get he's cyanotic, so he's got to have oxygen. Can't get them all right. Let's see. The most reliable indicator of upper airway swelling during a severe allergic reaction is I kind of want to quit guessing now that I got one wrong. Okay. Strider. High pitched sound um in the upper airway. The most common trigger of anaphylaxis is hmm, I'm gonna get this one wrong too. I'm gonna say D. Okay. Shellfish, peanuts are the most common triggers. The adult epi system delivers blank. Infant child system delivers blank. I believe it is B. 0.3 and 0.15. When administering epinephrine by autoinjector, the EMT should hold the injector in place for okay, B 10 seconds. So when we get in class, I've got two type of practice injectors. One is just your good old EpiPen injector. It doesn't talk to you, it doesn't do anything. Then I've got these little practice ones that are these little square boxes, and they are actually digital. They talk to you and walk you through it like an AED does. I learned 7 to 10 seconds. Your book says 10 seconds. When we get in class, that little automatic electronic one, it's going to tell you 2 seconds. Stick with the 7 to 10 because we have to make sure that we inject all the medication in. So the longer we hold it, the more chance we get all the medication pushed in. Guys, thanks for sticking it out with me. I know that went pretty fast. Not a super hard chapter, and I will catch you on the next one.